So today I'm going to talk to you a little bit about my first go at EMR implementation, some of the learnings that I had, what I could take across to my second go or take two EMR implementation. Hopefully I did do a better job the second time than we did the first time. And also I just thought I'd share with you just one small evaluation that we did where Adrian was talking about how we decreased waste by making a couple of simple adjustments in the EMR to make sure that we weren't wasting clinicians' time and we weren't increasing burden, which is really what we don't want to do. This was actually us go live day. Everyone else started at 3 a.m. or whatever the time is that you start. But of course, Allied Health aren't usually in the hospital, thank goodness, then. So we started, this was our Saturday morning, this is the ICU team heading off to the ward. Green super user, right in the front, this was one of our credentialed trainers and we were excited to get going. So first of all, I'm just going to talk a little bit about implementation that I did at Western Health, and I'll just let you read quickly about Western Health. So this was a Cerner implementation, and we really did inpatients only. It was very successful across the 5 sites. During the process, one of the things that we thought about is a problem that we had, which was around we were receiving electronic referrals at the time through IPM, and one of the teams, which is the Aspire team, which is sort of a quality team that we have in Allied Health there, decided that there was really an issue with the referrals that we were receiving. We were missing information, you didn't get the clinical information that you needed for Allied Health inpatients, and so therefore trying to prioritise where do I need to go, where do I need to start my day was really difficult. And what that did, it is actually impacted the time that Allied Health clinicians can spend with their patients. So you'll notice they were actually having to spend about 17 minutes to prioritise a single referral. Self-audit, maybe they wanted something to happen, so maybe they upped the numbers a little bit, but it's a significant amount of time. And that was from 800 referrals. So you can imagine the waste that goes into that is quite significant. So what we really asked the question, and this is the type of thing that you're going to be doing over the next while you're planning and building, how can we make it quick for the referrer, but how can we also make it useful for the Allied Health person who's receiving the information? What are the type of things that we can think about? So we had some people get together and think about what are the key things we need to know. Now you'll know if you've worked with Allied Health before, each area has a crazy matrix of prioritisation. Some areas might have priority 1, 2, 3. Someone else, the speech therapist team, I hate to say, had something like 14 priorities. And so that is not going to work. How can we teach someone else to get out this crazy matrix and make a decision? How do I make this a quick referral? So instead what we did was we had 4 options that were clinically relevant, and I'll show you them when we get to the next slide. We also had some defined reasons of referral, so no one actually had to type anything. It was very quick, so in 2 clicks pretty much you could sum up everything that we needed to know once the referral came to the other end. In Cerner you can sort of set up some auto-generated referrals. In Epic they don't do that, but more it sits within the best practice advisories. And I must say we had spent a lot of time trying to stop those auto-generated referrals coming through incorrectly. And so we did embed referrals within autosets. So what you'll see is 5 months after go live, we had 25,000 referrals that we could look at for us to make some decisions about whether this was working. And it was quick data out, a few pivot tables, and then we have the information that we need to be able to make decisions moving forwards. So you'll see, which is really difficult to read because it's sort of missing off the bottom of the screen there, but we had 4, when I talk about the clinical priorities, we just had 4, simple. We had the patient was at risk of clinical deterioration. The second one, that discharge was pending an Allied Health review. So as soon as an Allied Health clinician sees that, well, there's my P1s for the day already. Discharge greater than 72 hours, discharge within the next 72 hours. And that was the first decision that a clinician on the ward who was referring had to make. And you'll see what we were slightly concerned about, and this is something that we can check over time through the process, is that everyone would just choose the first selection, because I want to make it really quick, and particularly in that circumstance, it was a drop-down list. I'm going to choose the first one. So what we wanted to do was make sure by looking at the information, are people choosing the first one, or is actually this working like we had planned it to? And so you'll see we had about 15% of the referrals out of around 20,000 referrals, where clinical deterioration, it was about 15% of the referrals. Seems pretty reasonable. So we think this is actually working. So it was one thing to put it into the system, but then it was another thing to actually check back and say, is this working like we thought it would be? And you'll see for a particular team, for example, spiritual care, they had about 65% of their referrals, which was the patient was at risk of clinical deterioration. And that's when we would want the spiritual care team to be there. And again, that meant, right, we know where to start our day. And so just to give you a quick example of, from a social work perspective, these were the reasons for referrals they used. Again, really simple, but gave quick decisions to the clinicians. So if a referral came through where it was suspected a child at risk, elder abuse or family violence, again, that was their call. I know where I need to start my day. So this is just an example of one way that you can actually develop and build your system and design it to work well and to reduce the waste. So I have to say, it's not the EMR team. We weren't the ones that did this evaluation, so it wasn't us saying to everyone, write down how good we are. What it was clinicians re-evaluating with the Aspire unit, and then luckily that data was available. We used it later. So what you'll notice was a significant decrease in the amount of time for one task. One thing that we can do using electronic medical record, significant decrease of time and decrease in waste. From that first implementation that I was involved with, we did have a number of learnings that I'd just like to share with you, and then I took on to the next project. One thing that is allied health staff were particularly positive about the change on the whole, which was really great. And as we've already heard today, communication was really one of the key factors. So it's communicating early, it's communicating regularly, and it's building very strong connections with the teams that you're working with. What I think we needed to do better after the first implementation was actually we did develop standardised allied health workflows, but there was probably only a few of us in the room that made the decision, and we decided for better governance, actually, we needed to change that. And we needed to think about a framework again for standardisation, because there's such a wide variety of allied health professionals, but we'd like to have some commonality in how they were thinking about they were going to design and use the EMR. And I can't stress enough how important your super users will be at the end of this process when you're actually going live. And so early thinking about who's really keen and who's eager within my teams. I'm going to say this more than once. Do not overdo specific data entry fields, because people really hate them and they don't fill them in. And at the start in particular, it's really hard for them to see, to change and think, why am I doing this? This is just a really difficult process. Be prepared for curveballs. When you're on the project, you never know what's coming next. And as I'll say in the future, we had a huge curveball in implementation number 2. But in implementation number 1, you never know what's happening. And so I often think, what am I needing to deal with for the next 15 minutes? And then I can worry about outside of that, after that 15 minutes, with what's next. And I think from this particular implementation, one of the challenges was we were just adding an additional system, because we were only looking at inpatients, into an already, as we were hearing before, there might already be 130 systems in the system that the people are having to use. So after that first project, it is quite full on. You'll find at the end of this time that it's been a challenging time that you're working through. And I was looking forward to doing 6 months in business as usual, and then I was going to take a year and go travelling. unfortunately, a few of those things didn't work out. But first, there was a great opportunity for me with the Chief Allied Health Information Officer at Parkville. And so I said to my partner, I'm really sorry, I know we're going travelling, but I'd like to do this job. Then I had to come home and say, I'm really sorry, I got the job. So moving forward, I was actually really excited to move to implementation number 2, and I was super excited to see what Epic had to offer and how it was different, because if anyone's worked where you've done one implementation, there's always whispers about what the other vendor is like, and then whispers going back and forth. And it's interesting, when I've done both, everyone sort of whispers the same thing both ways. Anyway, so I was really excited about it. Now, Adrian gave you some of the details about the children's hospital. From the adult hospitals, we had a lot of staff. We have a lot of beds. And I was looking after about 800 allied health professionals from around 17 professions. And we did have our go live in August 2020, which was scary and exciting. And we did do big bang implementation. So it's high risk, high reward. I'm not going to really go over this much because Adrian had already touched on it, but as we've heard numerous times, clinical transformation, not an IT project, led by clinicians for clinicians. And Adrian's already gone through most of these points. What I did do early on was realised that, yes, I had some change management experience and I'd had a bit of experience with EMR, but the great thing about I found working with Epic is how amenable everyone else who is using Epic, they're just open to you coming and asking questions. For us, we were really lucky that we had the Royal Children's Hospital with the experience just down the road. And when I mean just down the road, it's about 10 minutes max on a slow day in the sun to walk from the Parkville precinct down to the Children's. And we could not have done what we did without their help. And we were happy to receive their assistance. And I would anticipate that you will also be looking for any assistance that can come along. So that meant we had some children's clinicians coming and giving overviews. This is how we're using Epic. This is why we really like it. These are the great things that we've done so far. And also from an allied health perspective, Greater Ormond Street was really helpful because in the US, the way that allied health work can be quite different to Australia and the UK. And they'd gone live about 1 year ahead, so it was a really great timing for them to give us information. Epic's network is amazing, and if you ever get the chance to go to UGM, it's amazing and crazy. There's a lot of people, there's a lot of information, but I've put 2 asterisks because there's not much information yet coming from allied health perspective, and it's certainly something that we would like to see in the future is more information coming out with research in this allied health clinical informatics space. And we did also visit MD Anderson while we were over there. So thinking about this clinical transformation, not for an IT project, what did we do? So as you've all established, we've got your subject matter experts from every profession. We had that within allied health. And it was really thinking about who's key. So it may not be the manager, but it may be a senior clinician, someone who's actually working on the floor, understanding our current workflows. They were great. We made sure as much as possible that allied health were included with any shared workflows, so multidisciplinary decisions. So is it around case conferencing? Is it around managing wounds? Where you've got a number of professions all working together. And just to let you know, our allied health super user ratio was 1:10 that we used at the precinct. From a standardisation perspective, we actually established an LMS. No, we didn't. We established an EMR, Allied Health Advisory Group. So we were the RAG. Terrible. Everything gets cut down. But they didn't have that when they went live at the Children's, and I think that we had representation from all of the organisations, including the Children's. Within this group, we had allied health directors, we had managers, and we had clinicians. And every decision that was impacting allied health came up through that group, and so that was our level of governance. If we had a decision that we couldn't come to, so all 4 health services had to say yes, If we couldn't come to a decision, then we had clinical counsel as our next level of governance to then assist with making a decision. But luckily, mostly Allied Health worked together really well, and I didn't have to take many things through to clinical counsel, which was great, but would have been more than happy to do it if we needed to. We also got together an Allied Health core group, and nursing did the same in the Parkville project, where they talked about what are all the commonality, what are we all doing the same, and how is the best way for us to do it the same. And within those, we actually brought someone from the children's in to give us extra advice. So we had someone who had done it before, and we were saying, oh, it might be amazing to do this. And they would say, actually, we tried that and it really wasn't successful. Or, great, we didn't even know that was possible. And so in the end, what we designed was things like an Allied Health navigator. So when someone comes into inpatients, everything that you needed to do was there in one space for you to work in. And interestingly, the children's have decided to actually adopt. So some of that now is going back even between the two projects. The two, sort of with the children's and the Parkville project. And then what we did after we had made a lot of these core content decisions, they all went back to advisory group for sign-off. And then we had some summits with our super users fairly early on. So we were starting to disseminate the decisions around why we're doing things this way. Why did we choose this level of standardisation in this way? And then from an Allied Health reporting and research capability point of view, where we started is really about Allied. We have some live reports around what is the demand for Allied Health today in the hospital. How many patients have we got who are awaiting Allied Health intervention for discharge? How many patients have we got at risk of clinical deterioration? Where do we need to send our staff immediately? So that we've got some decisions that we can make then and there, can sit with managers, senior clinicians, wherever. And we also have got some longitudinal data that we can look at. So I just wanted to show you this timeline. So this timeline is the number of daily cases of COVID in Victoria. And you'll see on here also our different time points. When we postponed in late March, we never anticipated that we would be going live at the peak of COVID within Victoria. But we did, and it was successful. And I think one of the main things was the drive from clinicians for us to be able to access information quickly, access information from home if required, not spend as much time on a hot ward if I could do some of my pre and post documentation and reading off the ward. So even though it was scary, we managed to do it and it was successful. Oh, sorry, they're not supposed to jump out. There's nothing too exciting about those two extra ones. I didn't realise. Oh, that's good news. You can't see that slide because it's just a big picture of my head. Yeah, oh, did it come through? Oh, yeah, sorry. Oh, yes. I didn't realise how big the screen would be. But one of the things we did, because we knew we were going into this COVID environment, we thought staff were challenged, staff were stressed. How are we actually going to do this communication? Because we know it's so key. So what we in Allied Health decided to do is we focused on our super users and we had a 15-minute catch-up every fortnight from May, which then became weekly until go live. So they knew what was happening. We did demos, whatever they needed, we ran through, and then we left it to the super users to decide within their teams when are they ready to hear this information. So we made sure we kept that communication. I'm just going to move it forward because I can't keep looking at my own head. We made sure that they knew what was going on and we let them take control of communicating within their teams, and I think that worked really well. We did have a successful go live. We had super users in PPE, on wards. We had remote support in America. We had remote support in Parkville. We had an amazing amount of support, and we were very lucky that it went extremely well, and Mallory would attest to it. It was a great implementation. So from the clinician's perspective, we have our we have a now post-live visit, which was our first post-live visits, which happened a couple of months after implementation. And this was the feedback we were getting. It's really easy to access information, documenting notes, communication, using secure chat. The uptake of that has been really great. We were able to connect better with our patients. So one of the ways that we are documenting our goals from an allied health perspective, when the patient leaves the hospital, they get what's called an after-visit summary, and within that are the goals that we've set with the patient about this is what we want to work towards. And we have this opportunity to make things cross-encounter. So when someone comes into ED and they tell us some information, well, we put it into the EMR, and then as they go through the system, we don't need to keep asking that question over again, which is really great. We've started sending out some proms before appointments through the portal so that when patients come to their first assessment, we've actually already got some information that they've completed, which is great. We use the similar information referral management system that I did on the first project, and we also worked with the patient journey board to think about how can we make what we're doing visible to everyone in the organisation. As I said before, we've got some cross-encounter information, and one of the big things we did was pop in a pre-morbid assessment, so it didn't matter who asked the questions, I didn't need to ask the question again. MDM and group documentation, case conference is all going really well. And we had, as I spoke to before, about that up-to-date inpatient clinical demand reports. Learnings from an allied health perspective, training, we ran some very generic allied health training. We did have to somehow, we left it to our super users to do, but provide some profession specific. If you want your teams to be documenting something in particular, then it's important that they're taught how to do it. We did a lot of so PRD is production, so checking that people can log into the system. So when we went live, most people could log into the system, but not everyone was day one ready. So when they logged in, they chose the wrong department to log in. And then they're saying, the screen doesn't look anything like I expect, and because if I log into a different department, it looks different. And also the patient lists that I need. So I think adding to your production check a couple of things about where should I be looking and what should I be looking at on day one is really critical. And we also had some difficulty with in-basket pools, and it took us a while to sort that out. There were some sort of sections which we would consider MDT care that allied health weren't quite in the room for. And so, for example, tracheostomy management. But it's something that we identified, and the great thing about Epic is that you're not stuck even in day 3 with what you started with at day 1. If you need something to be improved, you can work with the team and improve it. And it is a really big change from allied health to move from writing all of your notes to try and encourage you to put some data into other fields within the system. And so again, I say do not overdo data field entry. And over the next 12 months, we're hopefully going to finalise some evaluation that we've done from an allied health perspective. We're going to review how the clinicians are actually using the tools. So are things being used as we had anticipated? What do we need to do? We're going to increase the connection to our patients, so trying to really work with what we're calling Health Hub, which is the patient portal. And as Adrian spoke before about how we're going to do easier documentation when we're on the road and with virtual care. Particularly allied health managers, but also clinicians, we need to think about what reporting do we need to come out. Now we're putting information in. And I really feel once we can provide particularly clinicians with clinical information that they've put into the system, and we can say, here's some outcome measures of your pre and post for this particular patient, then we're going to have better buy-in with filling in those slightly annoying data fields. And finally, we've spent time pre-go live and we'll continue to upskill allied health in clinical informatics. We spent some time with clinicians pre-go live teaching them how to use some of the basic smart tools at a system level, and we're planning to continue that, which was really successful and has been extremely successful at Children's, particularly from an allied health perspective. Thank you very much for the opportunity to speak today, and I am willing to answer any questions at any point. Thank you.
Come
Oh,
on.
I thought I'd done my time.
Almost. Look, we might just do one quick
Sure.
question, and then we'll fire the MC for the day.
Yes.
Did you at Parkville in the precinct include community-based services, sort of occupational therapy, nursing, physio, etc., in the system, and how did that work? What was the difference between those services and the sort of more traditional admitted, not admitted, actually on the hospital campuses?
Yeah, so we had obviously our inpatients. We have quite a large outpatient. We have what in Victoria we call HIP services, which is get it right, health information programs. Maybe not. Can't remember. HIP programs. But pretty much what it is, it's looking after people in the community. So it's chronic, complex patients in the community under a HARP wing. We also have community therapy. So it's possibly patients who've been in subacute or acute, they've gone out to a community and we're supporting them. It's also home care. So that was factored in when we had our, get together, let's find out how things are going. We made sure we included clinicians from each of the health services, each of the professions, and inpatients and outpatients and community, so that we were capturing all that information in one. And as we move forward, we're going to try and continue, rather than little pockets doing something, trying to continue that standardisation. But it's actually been taken up really well in community because they take their laptop, they can read their notes as they go, can come out to the car or do their notes while they're in the community. Yeah, great.